So today we'll be talking about the thyroid gland. So quick overview. So what is the function of the thyroid? It's the function of the thyroid is in the name. It is to produce and store thyroid hormone, specifically thyroxine and our triiodothyronine, T4 and T3 respectively. It is located between C5 and T1, and it consists of two lobes, a left one and a right lobe, and connected in the center by the isthmus, which is basically a continuation of the lobes, but it forms the bridge between the two lobes. It is bound by pretracheal fascia, which you will learn more about in head and neck anatomy next semester. Like all other endocrine, the thyroid is no exception. It is highly vascularized to allow for the delivery of hormones into the bloodstream efficiently to work at their target organ sites. Specifically, arterial supply of the thyroid is given by our superior and inferior thyroid artery, whilst our venous drainage is given by our superior, middle, and inferior thyroid veins, named aptly so for their drainage being superior, middle, or below the thyroid gland. The surgical concern of the thyroid gland is during a thyroidectomy in some patients who might be suffering from a hyperthyroidism condition where a removal of the thyroid gland is indicated, stating that it would improve the condition that's happening. However, the thyroid gland is closely related to a number of structures, specifically one being most notable is our recurrent laryngeal nerve, which runs very closely beside it, as noted in the image down below here. And because of that, paralysis and damage may occur to the nerve if caution is not taken. That would result in the muscles of the hypothyroid muscles being impacted, leading to a hoarse voice. So now we know the function of the thyroid gland. It is to produce thyroid hormone. So how exactly is thyroid hormone synthesized? Well, it is synthesized in the follicular cells of the thyroid gland. The rough endoplasmic reticulum in our follicular cells synthesizes thyroid globulin, and it is then exocytosed into the follicular lumen, known as the colloid space. Iodine in the bloodstream then is uptaken by our follicular cells into the colloid space, where it then combines with our thyroid globulin to form either monoiodothyronine or diiodothyronine, MIT and DIT for short. These then combine to form either T3 and T4 thyroid globulins, as it's still bound to the thyroid globulin. What's interesting about this is that all the iodine in the body, up to 90% of it, is bound to thyroid globulin. And therefore, there is a large reserve of it found inside our colloid space. And therefore, in certain treatment regimes for disorders of the thyroid gland, it takes up a few months or up to a few weeks for the reserve to clear first before you see any noticeable changes in the patient's well-being. Now that we have T4 and T3 still bounded to the thyroid globulin in our colloid space, it is then endocytosed into the follicular cell and combined with lysosomes, which cleaves off the thyroid globulin base to leave us with T3 and T4, which diffuse into our bloodstream and affect their target organs. So now that we have T3 and T4, what is the difference between the two? T4 is, you can think of it as T4 being a less potent version of T3, but it has a longer half-life. Therefore, it is able to stay in the body and be utilized more often, especially with the case that T4 can be converted into T3, which is done by our peripheral tissues, specifically that of our liver, which enables us to have long-term T4 presence, which we can convert into T3 to increase metabolic functions in certain places when needed. Therefore, T3 is a more biologically active, potent form of T4, but due to that has a shorter half-life. Another form of T4 and T3 is reverse T3, which is basically T4, which is converted into a inactive T3. This allows for it to be excreted or broken down further to be recycled in the formation of new thyroid hormone in the thyroid gland. So now that we know the difference between T3 and T4, with T3 being the more potent and active form of T4, however having a shorter half-life, how exactly and what exactly do they do? They act to regulate the metabolic rate and temperature of the body by increasing it. How does it exactly do this? Well, it does it via binding and modulating transcription factors within the cell nucleus of target organs. This results in increased cardiac output, upregulation of our B adrenal receptors, which then increase our heart rate and the force of contraction. It also increases metabolism within the body by increasing our gut motility, stimulating lipolysis and the breakdown of our adipose tissue or the mobilization of fat. It increases the breakdown of muscles, increases gut motility and carbohydrate absorption, and increases our basal metabolic rate. As all of these other processes take energy, it results in the production of a lot of heat as a byproduct, as there is increased O2 consumption. This acts to promote neuronal development, bone growth, and skeletal development. As we know, everything in our body is in a constant state of homeostasis, with things shifting up and being modulated down to be within the normal range. Thyroid hormone is no different, and this is done by the hypothalamic pituitary thyroid axis. If this axis is skewed in some direction, then we have problems, which will lead to our hypothyroidism and our hypothyroidism conditions. So in a normal patient, what happens is that our thyrotropin releasing hormone, which is released from our hypothalamus in response to cold, stress, and following the circadian rhythm with its highs and lows throughout the day, releases our thyroprotein releasing hormone, which acts on our anterior pituitary, causing it to release thyroid stimulating hormone, which then stimulates the release of T3 and T4 from the thyroid. Secretion of T3 and T4 then acts as a negative feedback loop, inhibiting the release of thyroprotein releasing hormone as well as thyroid stimulating hormone once homeostasis is achieved, as we can see in the diagram here, where T3 acts as an inhibitor of our anterior pituitary as well as hypothalamus, and in this instant would prevent the release of any more